class is about geriatric pharmacology, the pharmacological aspects which are specific for geriatric patients. So, what is the age above which we call a patient as a geriatric patient or an elderly patient? So, society says whoever is above 65 years of age, they are called as elderly. Okay, but geriatrics, it should be, the term should be used for patients who are more than 75. So this is what some definitions says. So the definitions of the geriatric age group is arbitrary, and also age is only one of the many changes, okay, which are pertinent to the drug therapy of elderly patients. So apart from this age factor, elderly patients also have many problems to deal with. They have increased incidence of many diseases like Alzheimer's, Parkinson's disease, vascular dementia, stroke, visual impairment, atherosclerosis, coronary and peripheral vascular diseases, heart failure, diabetes, arthritis, osteoporosis, increased risk of fractures, cancer, urinary incontinence. So many problems they have to deal with. And apart from that, they have many nutritional problems and reduced financial resources. Elderly patients will have, they will face a lot of economic stress, and they have memory impairment, cognitive changes. So this may lead to poor adherence to drug therapy, and also they will have depression, because most of the elderly, they will lose their spouse, so which may cause depression. So all these problems you have the elderly patients are dealing with. So the important pharmacokinetic changes which happens in the geriatric patients or decrease in the body water. Okay, so the body water, total body water percentage decreases, the lean body mass decreases, the percentage of body fat increases, there will be decrease in the serum albumin, there will be decrease in the kidney weight, and there will be decrease in the hepatic blood flow. So all these pharmacokinetic changes have an impact on drug therapy of elderly patients. There will be changes in the absorption of the drugs you are prescribing because of change in the gastric emptying. So the patients may take antacids and laxatives as a routine, so which may cause change in the gastric emptying and which will have an impact on the absorption. And similarly, there will be decreased apparent volume of distribution because of reduction in the lean body mass and reduction in the body water. So apparent volume of distribution decreases, and also reduced albumin content means reduced bound form of acidic drugs. So there will be increased free concentration of acidic drugs, which may lead to toxicity. So the dose has to be reduced. And similarly, we saw that the hepatic blood flow decreases, and also because of malnutrition and also many diseases, the hepatic function also get affected. And similarly, the patients will be having heart failure more frequently, which may further decrease the hepatic blood flow. So all these changes will impede the metabolism of the drugs. And similarly, there will be changes in elimination also. So there will be decline in the creatinine clearance. So the renal function slows down and there will be decline in the creatinine clearance. So you have to be careful in dosing the drugs which are eliminated by renal mechanism. So Cockcroft-Gault formula is a formula which is used to calculate the creatinine clearance of the patient and calculate the dose of the drug according to the creatinine clearance. So the formula is 140 minus age into weight in kilogram divided by 72 into serum creatinine in milligrams per deciliter. So this will give the creatinine clearance, and then you have to calculate the dose according to the creatinine clearance. And now you have many online calculators available to calculate the creatinine clearance and the dose of the drugs accordingly. And the respiratory capacity is also reduced. So because of that, the volatile drugs elimination is affected. So like inhalation anesthetics. So the inhalation anesthetics is eliminated by lungs, through lungs. So because of reduced respiratory capacity, their elimination is also affected in elderly patients. So the pharmacodynamic changes. So apart from pharmacokinetic changes, there are changes in characteristics and number of certain receptors also. Okay, for example, uh, the elderly patients will have reduced sensitivity to beta 2 agonist drugs because of changes in the sensitivity of beta 2 receptors. And similarly, there are many physiological alterations. For example, the average blood pressure increases, and they are more prone to develop orthostatic hypotension, and there will be impaired temperature regulation. Okay, so because of this, the drug effect also changes. So the drugs which have alpha blocking property, so they cause more orthostatic hypotension in elderly. We will now see certain important group of drugs which should be used with greater caution among elderly patients when compared to young adults. So the central nervous system drugs, especially sedatives and hypnotics. So when you are using benzodiazepines, there is more chance of occurrence of adverse effects like ataxia and other impairment in the stability. So which may lead to increased fall and fractures in the elderly patients. So already their bones are weak and they will have osteoporosis, and these sedatives and hypnotics will impair the stability also, so this may cause increased risk of fractures and falls, so you should be very careful in the dose. And similarly, opioid analgesics, so there are two problems with the use of opioid analgesics. So most of the patients, they need opioids for their pain management. So you should always make sure that opioids are properly utilized. So because of the fear, you should not give underdose. Okay, so because adequate pain relief should be the goal, so opioids should be adequately used, but at the same time it should be used with caution, because respiratory depression is more with the elderly patients. So opioids should be cautiously used but adequately used. And similarly, uh, patients taking antipsychotics and antidepressants, so they will have more adverse effects because of the anti-muscarinic activity. Okay, so all the antipsychotics and many antidepressants, they have anti-muscarinic action as well. So this anti-muscarinic action may increase the intellectual dysfunction and memory loss the patient already having. Okay, and similarly, the alpha blocking action of these drugs will increase the risk of orthostatic hypotension. And similarly, many patients will have psychotic depression, but it will be mistaken as senile dementia. So the patient depression will be underdiagnosed. Okay, so most of the patients will have senile dementia, so it will be mistaken for the psychotic depression. So the depression should always be looked out and treated. And among cardiovascular drugs, so antihypertensive drugs are very important. So usually thiazides are the first group of drugs which are prescribed for elderly patients, but thiazides always have adverse effects like hypokalemia, hyperglycemia, and also hyperuricemia. And these adverse effects are more important in the elderly patients because they are more prone to develop arrhythmias, and they usually have type 2 diabetes mellitus and more chance of occurrence of gout in elderly. So the adverse effects should be carefully monitored. And usually calcium channel blockers are safe and effective in elderly, and AC inhibitors and beta blockers are less useful in older patients, so they should be mostly avoided as first choice of drugs. And digoxin, so most of the elderly patients, they have heart failure, so digoxin is frequently prescribed, but the toxicity of digoxin is increased because of poor renal elimination, so it should be carefully monitored. And antiarrhythmic agents, when they are used in elderly patients, they also have more toxicity because of reduced clearance. And the atrial fibrillation is a very common arrhythmia which occurs in the elderly patients. So prevention of thromboembolic episodes because of this atrial fibrillation should be taken care of with the use of adequate anticoagulants. And use of antimicrobial drugs, there will be reduction in the host defense mechanism in elderly patients. So the T cell function will be altered, and the mucociliary clearance in the lungs is decreased, and there will be more chance of urinary retention, and many patients will be catheterized. Because of all these factors, the risk of acquiring infection is very high in elderly patients. So this accompanied with decreased renal function, so this will cause more toxicity of antimicrobial agents. Okay, so because of increased risk of infection, there will be a need for prescription of more antimicrobial drugs, but the renal function will be decreased. So the drugs which are eliminated by kidneys should be used very cautiously. Okay, like aminoglycosides and other antimicrobials which are eliminated by kidney, they should be used very cautiously in elderly patients. Osteoarthritis is a common problem faced by many geriatric patients. So commonly we use NSAIDs and corticosteroids for osteoarthritis. So when we are using NSAIDs, we should be very careful because NSAIDs will impair the renal function. So which is already compromised. So it will impair the renal function, and again impaired renal function will cause accumulation of NSAIDs and increase the toxicity. So it is a vicious cycle. So use of NSAIDs must be very carefully monitored. And corticosteroids can be used, but again corticosteroids carry the risk of osteoporosis, so they already have weak bones, so which may be increased with the use of corticosteroids. So there will be increased incidence of adverse drug reactions in geriatric patients. So what are the points which you should remember while prescribing drug for geriatric patients? So we say brown bag analysis should be done by family physicians. So what is that brown bag analysis? So family physicians which are treating the geriatric patients, so they should periodically ask the patients to take all the drugs. So whatever they take, whatever they are taking, including over the counter drugs, the herbal preparations, so what are all the drugs they are taking, they should put all the drugs in a bag and they should bring to the family physician, and he or she should review the drugs. So sometimes the drugs are duplicated because the patients may see different practitioners for different ailments. Okay, so they may take same drug but with different brand names, or they may take drugs with similar mechanisms of actions. So this may cause many drug interactions and increased toxicity. So family physicians should review the drugs which are taken by elderly patients periodically, and it should be monitored closely. And as we discussed, they used to take non-prescription drugs also over the, because they suffer many joint pains, weakness, so for which they may take over the counter drugs and some herbal preparations. So herbal preparations are not completely safe. They contain many unknown ingredients, so which may be a metabolic inducer or inhibitor, so which may cause many drug interactions. Okay, and sometimes practitioner error also occurs. So many practitioners, they overlook the pharmacokinetic changes which happen in the geriatric patients, and they may overdose the patients. And similarly, they are more prone to have drug interactions because of polypharmacy. They take many drugs for multiple ailments, so which may increase the chance of many drug interactions. So all this should be reviewed periodically. Okay, so Alzheimer's disease is a very common disease which affect the geriatric patients. So it is a progressive degenerative disease which cause memory impairment, dementia, and cognitive dysfunction. So this occurs due to deposition of amyloid beta peptide and also intra and interneuronal fibrillary tangles consisting of the tau protein. So you can see here. So this is the small purple things. So these are all the amyloid beta peptides. Okay, so they are deposited in the extracellular spaces. Okay, so they are deposited as patches in the extracellular spaces. Okay, you can see here this is the amyloid plaque which is formed due to amyloid beta peptide. And also you can see here this is the neurofibrillary tangle. So this consists of tau protein. So all this deposition, it impairs the activity of the neurons. So especially loss of cholinergic neurons are seen with Alzheimer's disease, which impairs the cognitive function. So the drug therapy of Alzheimer's. So these are all the strategies, with Alzheimer's drug therapy. So use of cholinesterase inhibitors. So we know that there is a loss of cholinergic neurons in Alzheimer's. So we use cholinesterase inhibitors, and there is also a theory that excitotoxicity may be a reason for the development of Alzheimer's disease. So we can use NMDA antagonists. Okay, and similarly, modifiers of glucose utilization like PPAR gamma agonist is also tried with Alzheimer's disease, and anti-lipid drugs like statins also have off-label use, and retinoid X receptor like bexarotene, so it is transiently reduced, so it is shown to be reducing the A beta peptide in mice, and NSAIDs was also tried, but disappointing results with COX2 inhibitors occurred, and anti-amyloid vaccines are in clinical trials, and anti-amyloid antibodies were tried, but it failed in the further clinical trials, and inhibitors of amyloid beta synthesis, okay, like gamma secretase modulator. So these studies are in progress, and microtubule stabilizers. Okay, so it was shown, it was studied that microtubule disassembly favors the deposition of the neurofibrillary tangles. So drugs which inhibit this disassembly prove to be effective in Alzheimer's disease. And similarly, anti-cytokine antibodies, antioxidants, nerve growth factors, and all these drugs were under constant review, but many have proved to be ineffective. So the drugs which we use currently, anticholinesterases or the drugs of choice. Okay, you have four drugs: tacrine, donepezil, rivastigmine, galantamine. So these drugs have higher CNS penetration, and hence these four drugs are preferred for Alzheimer's treatment. And you have NMDA antagonist memantine, and a drug that inhibit microtubule disassembly, epothelone. So it is a drug which is used for cancer chemotherapy, and this also has a role in Alzheimer's disease. And another disease which commonly affect the elderly patients is age-related macular degeneration. So it is a common cause of blindness in developed countries. So you also have cataract, glaucoma as common cause of blindness, and apart from that you have macular degeneration also. So there is a theory saying macular degeneration is due to oxidative stress. So antioxidants can be tried, and similarly monoclonal antibodies against vascular endothelial growth factors like bevacizumab and ranibizumab. So these two drugs are used, and similarly oligopeptide pegaptanib is also used for age-related macular degeneration. So these are all the take-home points for you. While treating elderly, you should always take a careful drug history. So many of the symptoms the patient may say to you can be due to drugs. So it can be drug related, or it can be due to an adverse reaction of the drug, or it can be due to some drug interactions. So you should not go blindly and treat the symptom alone. So you should always take a very careful drug history to exclude that the symptoms are not drug related, and then go for treatment. And you should prescribe only for specific and rational indication. Okay, so you should not always use a proton pump inhibitor for any symptom of dyspepsia. Okay, so it should be specific and rational, and you should define the goal of drug therapy. So after the goal is defined, we have to start with very small doses and then titrate to the response desired. So if the patient is not showing desired response, you should always wait for 3 to 4 half-lives to get completed, and then you have to check the blood level, if adequate blood level is obtained or not, and then only you have to or increase the dose or change the drug. Okay, and you should always maintain a high index of suspicion regarding drug reactions and interactions. So this you should always keep in mind. So many symptoms can be due to drug reactions or interactions. So this should always come first in your mind. And you have to simplify the regimen as much as possible. So reduce the number of drugs as much as possible, and even if multiple drugs or need to be given, so make sure that most of the drugs are taken at similar point of time, so that the patient will not forget, so the complaints can be improved. Okay, so club the drugs so that the drugs are taken at the same point of time. Okay, so these are the points you should keep in mind while treating the elderly patients. Thank you.